In this chapter, we'll focus on secondary open-angle glaucoma, a group of conditions where the anterior chamber angle remains open but elevated intraocular pressure develops due to another underlying cause. These cases differ from primary open-angle glaucoma because the trigger is identifiable and treatment must address both the pressure and the root cause. Next, we'll review the key highlights of this topic. Secondary open-angle glaucoma can arise from a variety of distinct mechanisms. The most common cause is pseudoexfoliation syndrome, where abnormal fibrillar material accumulates on ocular structures, leading to increased outflow resistance. Lens-induced inflammation, whether from a mature cataract or lens material released after surgery or trauma, can also trigger this condition. Ocular inflammatory syndromes, such as uveitis, may cause pressure elevation both through the inflammatory process itself and through the effects of steroid treatment. Trauma, either accidental or surgical, is another significant contributor, with damage to the trabecular meshwork or angle structures impairing aqueous drainage. Finally, repeated intravitreal anti-VEGF injections have been associated with sustained intraocular pressure elevation, likely due to microscopic changes in the trabecular outflow pathways. In the next slides, we'll explore these causes in greater depth, beginning with pseudoexfoliation syndrome. Pseudoexfoliation syndrome is the leading cause of secondary open-angle glaucoma worldwide. It results from the production and accumulation of abnormal extracellular fibrillar material within the anterior segment. These deposits can be seen on the lens capsule, the pupillary margin, the ciliary epithelium, and various iris structures, as well as in the subconjunctival tissue. Interestingly, this material is not confined to the eye. It has also been detected in systemic tissues, including the skin, lungs, heart, and liver, suggesting a broader systemic process. Genetically, mutations in the LOXL1 gene are strongly associated with pseudoexfoliation, yet they are also found in many individuals who never develop the condition, pointing to a multifactorial etiology that involves both genetic and environmental influences. The exact interplay between these factors is still not fully understood, but recognizing the condition's systemic and ocular components is key to effective diagnosis and management. Clinically, pseudoexfoliation syndrome is most often asymmetric, typically beginning in one eye, with the fellow eye becoming involved later. It is strongly age-related, rarely occurring before the age of 50 and most commonly seen after 70. The hallmark sign is the bullseye pattern of fibrillar deposits on the anterior lens capsule, best appreciated after dilation. This pattern develops because the iris rubs against the lens during movement, scraping away material and leaving a clear intermediate zone between the central and peripheral deposits. In addition to the lens capsule, these deposits can appear on the pupillary margin, zonules, ciliary processes, the inferior angle of the anterior chamber, the corneal endothelium, and even the anterior vitreous. Recognizing these characteristic findings is essential for diagnosis, as they not only define the syndrome but also signal a higher risk for developing secondary open-angle glaucoma. Beyond its classic lens findings, pseudoexfoliation syndrome often presents with several additional ocular changes. Peripupillary atrophy is common, producing transillumination defects when light passes through areas of iris tissue loss. Pupillary dilation is frequently poor, as the fibrillar material infiltrates the iris stroma and restricts its movement. Weakness of the zonular fibers can lead to phacodonesis, where the lens trembles with eye movement, signaling a higher risk of surgical complications such as zonular dehiscence, vitreous loss, or even lens dislocation. On iris angiography, abnormal vessel patterns with fluorescein leakage may be seen, reflecting the vascular involvement of the disease. These findings not only aid in diagnosis, but also alert the clinician to potential surgical challenges and the need for careful preoperative planning. On gonioscopy, pseudoexfoliation syndrome often reveals a heavily pigmented trabecular meshwork, sometimes with pigment deposited anterior to Schwalbe's line, forming what is known as a Sample-Lessy line. This pigment dispersion results from chronic shedding of material and iris pigment into the aqueous. Additionally, zonular laxity can allow the lens to shift forward, predisposing the patient to secondary angle closure. Recognizing these gonioscopic features is critical, not only for diagnosis, but also for anticipating potential complications in both disease progression and surgical management. Pseudoexfoliation glaucoma develops when the fibrillar material characteristic of pseudoexfoliation syndrome obstructs aqueous outflow through both the conventional and uveoscleral pathways, leading to elevated intraocular pressure. Involvement of elastin within the lamina cribrosa may make the optic nerve more susceptible to damage, which is supported by findings from the early manifest glaucoma trial. Clinically, pseudoexfoliation glaucoma is defined by the combination of pseudoexfoliation material, elevated intraocular pressure, and evidence of optic nerve damage or visual field loss. It occurs in all populations, though prevalence varies widely, accounting for up to half of open-angle glaucoma cases in some Scandinavian countries. The condition is often more aggressive than primary open-angle glaucoma, with higher pressure levels, greater diurnal fluctuations, and a generally worse prognosis. While laser trabeculoplasty can be effective, its benefits may be shorter-lived compared to its use in primary open-angle glaucoma. Early recognition and close monitoring are essential to slow progression and preserve vision. Here we see the classic appearance of pseudoexfoliation material on the anterior lens capsule, displayed in a fully dilated eye. The fibrillar deposits form a distinct bullseye pattern with a central zone, a clear intermediate ring, and a peripheral band of material. This configuration occurs because the iris rubs against the anterior lens surface during normal movement, mechanically clearing the intermediate zone while leaving deposits in the central and peripheral areas. Recognizing this pattern during slit lamp examination is a key diagnostic clue for pseudoexfoliation syndrome, often prompting further evaluation for associated glaucomatous damage. In this image, we see pseudoexfoliative material accumulating along the pupillary margin and extending onto the anterior lens capsule in an undilated eye. These whitish, flaky deposits often appear in a radial distribution, following the natural architecture of the iris. At this stage, before dilation, the full bullseye lens pattern may not be visible, but the pupillary margin changes can still serve as an important early clue to the diagnosis. Careful slit lamp examination for these subtle deposits can allow detection of pseudoexfoliation syndrome before more advanced glaucomatous damage develops. This gonioscopic photo shows the anterior chamber angle in an eye with pseudoexfoliation syndrome. The black arrows highlight the Sample-Lessy line, pigment deposition located anterior to Schwalbe's line. The white arrows indicate the anterior border of a heavily pigmented trabecular meshwork, a finding often seen in this condition due to chronic liberation of pigment and fibrillar material into the aqueous. These gonioscopic features are important for confirming the diagnosis and understanding the mechanisms that can contribute to elevated intraocular pressure in pseudoexfoliation glaucoma. Moving on to pigment dispersion syndrome, which occurs when the zonular fibers rub against the posterior iris pigment epithelium, releasing pigment granules into the anterior segment. This process is often linked to reverse pupillary block, which causes the posterior iris to bow backward and increases contact with the zonules. Classic signs include pigment on the corneal endothelium, known as a Krukenberg spindle, which forms in a vertical spindle pattern due to aqueous convection currents and endothelial phagocytosis. Pigment can also accumulate on the trabecular meshwork and the lens periphery. The rubbing results in mid-peripheral iris transillumination defects that appear spoke-like. On gonioscopy, the angle shows dense, homogeneous pigmentation with or without speckling, sometimes extending anterior to Schwalb's line to form a Sample-Lazy line. Pigment may also deposit on the zonular fibers, the anterior hyaloid, and the equatorial lens capsule, where it can appear as a Zentmeyer line or Shaya stripe. These findings are key for diagnosis and for recognizing the potential risk of secondary open-angle glaucoma. Over time, the signs of pigment dispersion syndrome may diminish, particularly as the lens thickens with age and pushes the iris forward, reducing the posterior bowing and zonular contact that drive pigment release. Pigment granules already deposited on the cornea, trabecular meshwork, and iris surface can gradually fade. While most patients remain stable, about 15% will either progress to glaucoma or require treatment to lower intraocular pressure, a condition known as pigmentary glaucoma. This form of glaucoma is 3 times more common in men, particularly those who are myopic and between the ages of 20 and 50. It results from trabecular meshwork obstruction by pigment granules and is notable for large pressure fluctuations, sometimes exceeding 50 millimeters of mercury in untreated cases, which can be triggered by exercise or pupillary dilation. Recognizing these patterns is essential for monitoring at-risk patients and intervening before significant optic nerve damage occurs. Management of pigment dispersion in pigmentary glaucoma begins with medical therapy, which is typically effective in lowering intraocular pressure. Laser trabeculoplasty can also produce a good response, though the effect may be shorter-lived in this population. Because heavily pigmented trabecular meshwork carries a risk of paradoxical pressure spikes, lower laser energy settings should be used. Filtering surgery is another effective option, but carries a higher risk of hypotony maculopathy in young, myopic men, making careful case selection essential. Laser peripheral iridotomy has been proposed to reduce posterior iris bowing and limit pigment release, but randomized trials have shown no proven benefit, so its use remains controversial. Ultimately, the choice of treatment should be individualized, balancing efficacy with the unique risks in this patient population. This image shows a Krukenberg spindle in a patient with pigmentary glaucoma. The spindle appears as a vertical, spindle-shaped deposit of pigment on the central corneal endothelium. This distribution results from convection currents in the aqueous humor, which carry liberated pigment granules upward along the warmer iris and downward along the cooler cornea, where they are phagocytosed by endothelial cells. This photograph shows the classic spoke-like iris transillumination defects seen in pigment dispersion syndrome. These defects occur when the posterior iris pigment epithelium is lost in a radial pattern, allowing light to pass through and reveal the underlying reddish-orange glow from the fundus. The spoke configuration reflects the arrangement of the iris's structural support and its contact points with the zonular fibers. Detecting these transillumination defects on slit lamp examination is a key diagnostic sign, often prompting further evaluation for pigmentary glaucoma. This gonioscopy image demonstrates the characteristic heavy, uniform pigmentation of the trabecular meshwork seen in pigment dispersion syndrome and pigmentary glaucoma. The dense, even distribution of pigment, indicated by the arrows, results from the chronic release of pigment granules from the posterior iris pigment epithelium and their deposition within the trabecular meshwork. This image shows pigment deposits on the equatorial region of the lens capsule, known as a Zentmeyer ring or Shy stripe, which are characteristic of pigment dispersion syndrome. These deposits form as liberated pigment granules from the posterior iris pigment epithelium, settle along the zonular fibers and at the lens equator. Their location corresponds to areas of mechanical contact between the iris and the lens zonule complex. This UBM sequence shows the iris configuration in pigment dispersion syndrome. In the left image, before laser peripheral iridotomy, the iris has a concave configuration, bowing backward toward the zonules. This posterior bowing increases mechanical contact between the iris and zonular fibers, promoting pigment release. In the right image, after laser peripheral iridotomy, the posterior bowing has resolved and the iris assumes a flatter profile. While this anatomic change supports the theory of reverse pupillary block and pigment dispersion, clinical studies have not demonstrated a consistent reduction in pigment release or intraocular pressure, which is why the role of iridotomy in managing this condition remains controversial. Lens-induced glaucoma refers to glaucomas in which the lens plays a primary role in raising intraocular pressure, and it can present as either an open-angle or angle closure mechanism. In the open-angle category, there are three main subtypes. Phacolytic glaucoma occurs when high molecular weight lens proteins leak from a hypermature cataract into the anterior chamber, triggering inflammation and blocking outflow. Lens particle glaucoma develops when cortical lens material enters the anterior chamber, often after surgery or trauma, leading to trabecular obstruction. Phacoantigenic glaucoma is an immune-mediated response to lens proteins, resulting in granulomatous inflammation and outflow compromise. Angle closure forms of lens-induced glaucoma will be discussed in detail in Chapter 10, but they include phacomorphic glaucoma, caused by lens swelling that crowds the anterior chamber, and ectopia lentis, where lens displacement disrupts normal aqueous flow. Recognizing whether the mechanism is open angle or angle closure is essential, as it directs both immediate management and definitive treatment. Phacolytic glaucoma is an inflammatory form of glaucoma caused by the leakage of high molecular weight lens proteins from a mature or hypermature cataract. These proteins escape through microscopic openings in the lens capsule. As the lens ages, the concentration of these large proteins increases, making leakage more likely. Once in the anterior chamber, the proteins, along with macrophages loaded with lens material and other inflammatory debris, obstruct the trabecular meshwork. This blockage reduces aqueous outflow and leads to elevated intraocular pressure. Recognizing this mechanism is important because prompt treatment addresses both the pressure elevation and the underlying lens pathology. Phacolytic glaucoma typically presents in older patients with poor baseline vision, often due to a mature or hypermature cataract. Onset is sudden, with symptoms of ocular pain, conjunctival redness, and worsening vision. Examination usually reveals markedly elevated intraocular pressure, microcystic corneal edema, and a prominent anterior chamber cell and flare without chorotic precipitates, an important feature that helps distinguish it from phacoantigenic glaucoma. The anterior chamber angle remains open, and signs of a mature cataract are present. In some cases, a pseudohypopion or large white clumps of lens protein can be seen, and in Morganian cataracts, wrinkling of the anterior lens capsule may be visible. Management begins with ocular hypotensive therapy to control intraocular pressure. However, definitive treatment requires cataract extraction, which removes the source of lens protein leakage and resolves the underlying inflammatory process. These images depict classic findings in phacolytic glaucoma. The smaller image shows a hypermature cataract, with the lens cortex liquefied and the capsule appearing wrinkled and irregular. The larger image illustrates the acute presentation, with marked conjunctival hyperemia, microcystic corneal edema, and a dense anterior chamber reaction. Lens protein aggregates can be seen on the corneal endothelium and layered inferiorly in the anterior chamber, forming a pseudohypopion. This layering occurs as high molecular weight lens proteins leak from the compromised capsule, are engulfed by macrophages, and settle in the angle, obstructing aqueous outflow. Let's move on to the next lens-induced open-angle glaucoma, lens particle glaucoma. Lens particle glaucoma occurs when retained lens material, often cortical, remains in the anterior chamber after cataract surgery, capsulotomy, or ocular trauma. The trabecular meshwork becomes obstructed by these particles. The severity of intraocular pressure elevation depends on how much lens material is present, the degree of inflammation, how well the trabecular meshwork can clear debris, and ciliary body function, which can be altered after surgery or trauma. Onset is usually within weeks of surgery or injury, but may occur months or even years later. Clinically, you may see cortical material in the anterior chamber, elevated intraocular pressure, moderate anterior chamber reaction, and microcystic corneal edema. Chronic inflammation can lead to posterior or peripheral anterior synechiae. Management includes medical therapy to reduce aqueous production, mydriatics to prevent synechiae, and topical steroids for inflammation. If pressure remains uncontrolled, surgical removal of residual lens material is necessary. Now let's move on to phacoantigenic glaucoma, a rare immune-mediated reaction to one's own lens protein. This typically occurs after cataract surgery or penetrating ocular trauma when lens material becomes exposed to the immune system. The underlying pathophysiology involves a granulomatous inflammatory response triggered by sensitization to lens proteins, which are normally sequestered. Clinically, patients often present with a moderate anterior chamber reaction. You may see choretic precipitates on both the corneal endothelium and anterior lens surface. Other findings can include low-grade vitritis, posterior synechia, and peripheral anterior synechia. Residual lens material is often present in the anterior chamber, but glaucomatous optic neuropathy is uncommon in this condition. Management focuses on controlling inflammation and IOP. Topical corticosteroids are used to suppress the inflammatory response, while aqueous suppressants help reduce pressure. Definitive treatment involves removal of the lens material, but only after the inflammation has subsided to avoid exacerbating the immune reaction. Let's talk about the next type of secondary open-angle glaucoma, intraocular tumors. On this slide, we discuss how intraocular tumors can elevate intraocular pressure and cause unilateral glaucoma. These tumors can directly invade the anterior chamber angle, blocking aqueous outflow. They may also cause angle closure by rotating the ciliary body or displacing the lens iris diaphragm forward. Intraocular hemorrhage is another potential cause, as is neovascularization of the angle, which can lead to fibrovascular membrane formation and secondary synechial closure. Finally, tumor cells, inflammatory cells, or other debris can deposit in the trabecular meshwork, further impairing aqueous drainage. Intraocular tumors can elevate intraocular pressure and cause secondary glaucoma through several distinct mechanisms. Choroidal and retinal tumors may lead to secondary angle closure by pushing the lens iris diaphragm forward. Inflammatory responses to necrotic tumor tissue can form posterior synechia, worsening angle closure via a pupillary block mechanism. Examples include choroidal melanoma, medulloepithelioma, and retinoblastoma. Additionally, these tumors can stimulate neovascularization in the angle, which may also be seen after radiation therapy. Ciliary body tumors are especially likely to cause pressure elevation because they can directly invade the anterior chamber angle. They may also produce inflammation and intraocular hemorrhage, further blocking aqueous outflow. Necrotic tumor tissue or tumor-laden macrophages can accumulate in the trabecular meshwork, resulting in secondary open-angle glaucoma. Clinically, the tumors most often associated with glaucoma in adults are uveomelanoma, melanocytoma, metastatic carcinoma, lymphoma, and leukemia. In children, retinoblastoma, juvenile xanthogranuloma, and medulloepithelioma are the most common offenders. This image shows a gonioscopy view of a ciliary body melanoma extending into the anterior chamber angle. You can see a pigmented, irregular mass occupying the angle structures, which is a classic finding in this type of tumor. Ciliary body melanomas can cause elevated intraocular pressure through direct invasion of the trabecular meshwork, leading to impaired aqueous outflow. Recognizing this appearance is critical because prompt diagnosis not only guides glaucoma management, but also influences systemic evaluation and tumor treatment planning. Here we see a ciliary body melanocytoma in the anterior chamber angle. This lesion appears densely pigmented and nodular, with a more granular surface compared to melanoma. While benign, it can still cause angle crowding and secondary intraocular pressure elevation. Let's now discuss uveitic or inflammatory glaucoma, focusing on how inflammation contributes to intraocular pressure elevation and what conditions are often associated with it. Inflammatory processes within the eye can lead to trabecular meshwork edema or direct endothelial dysfunction, impairing aqueous outflow. Inflammatory cells or fibrin can physically block the trabecular meshwork or Schlemm canal. In some cases, corticosteroid use for inflammation control can paradoxically reduce outflow, further worsening the pressure rise. Chronic inflammation may also result in the formation of peripheral anterior synechiae, creating a mechanical blockade. Additionally, prostaglandin-mediated breakdown of the blood-aqueous barrier can promote further inflammatory and vascular changes. Several systemic and ocular conditions can be linked with uveitic glaucoma. These include Fuchs' uveitis syndrome, herpetic keratouveitis from herpes simplex or herpes zoster, toxoplasmosis, juvenile idiopathic arthritis, and pars planitis. Recognizing these associations can guide clinicians toward the underlying etiology. Clinically, key clues point to the inflammatory nature of the glaucoma. The presence of keratic precipitates on the corneal endothelium should raise suspicion for anterior uveitis as the source of pressure elevation. Gonioscopic examination may reveal subtle trabecular meshwork precipitates, peripheral anterior synechiae, posterior synechiae, and in some cases, iris Bombay configuration, which can precipitate secondary angle closure.
On this slide, we focus on key management considerations for uveitic glaucoma. The primary goal is controlling inflammation, but our treatment choices must balance this with potential effects on intraocular pressure. Corticosteroids remain the mainstay to reduce inflammation, though they can sometimes raise IOP. Miotics are generally avoided as they can worsen inflammation and promote posterior synechia formation. Prostaglandin analogs have a possible risk of exacerbating inflammation, but they can be beneficial for select patients. It's also important to recognize that some patients with uveitic disease may present with low IOP. This can result from increased uveoscleral outflow, shutdown of the ciliary body, or even ciliary body detachment. During active inflammation, measurements of aqueous flow can be unreliable, so clinical judgment is essential in guiding therapy.
This slide covers glaucomatous-cyclitic crisis, also known as Posner-Schlossman syndrome, an uncommon form of open-angle inflammatory glaucoma. It presents with acute unilateral episodes of markedly elevated intraocular pressure, typically in the range of 40 to 50 millimeters of mercury. This is accompanied by low-grade anterior chamber inflammation. It most commonly affects middle-aged adults, and symptoms often include unilateral blurred vision and mild ocular pain. On examination, there is mild anterior uveitis with a few small, round keratic precipitates, which typically resolve within weeks. Gonioscopy may reveal keratic precipitates on the trabecular meshwork, a finding sometimes described as trabeculitis. Corneal edema may also be present. The course is characterized by intraocular pressure returning to normal between episodes. However, recurrent episodes can lead to chronic secondary glaucoma over time. Now that we've reviewed the presentation and clinical course, let's move into the etiology and diagnosis of glaucomatous-cyclitic crisis. The exact cause is still unknown, but there are possible associations, including certain infections such as herpes simplex virus, cytomegalovirus, and Helicobacter pylori, as well as autoimmune disease. This condition can sometimes be mistaken for recurrent acute primary angle closure. Interestingly, some cases that were initially thought to be glaucoma dose cyclitic crisis were later found to be CMV positive through aqueous PCR testing. Clinically, this distinction is important because if CMV is the culprit, targeted antiviral therapy is available. Let's now turn our attention to the management of glaucoma dose cyclic crisis. The primary goals are to control intraocular pressure and reduce inflammation. IOP can be managed with topical and sometimes oral ocular hypotensives. Anti-inflammatory therapy typically involves topical corticosteroids with topical or oral NSAIDs, such as indomethacin, as alternatives. Prostaglandin analogs, while sometimes helpful, may worsen the condition and are reserved for select patients. Long-term suppression with chronic topical NSAIDs or steroids has shown no proven benefit. In cases of advanced optic nerve damage or frequent IOP spikes, filtering surgery may be considered. Let's shift our focus to another distinct but important uveitic entity, Fuchs' uveitis syndrome. Previously known as Fuchs' heterochromic iridocyclitis, this condition is a rare, chronic, and often insidious form of usually unilateral uveitis. It does not favor any particular race or sex and most often begins in young to middle-aged adults. Key clinical features include iris heterochromia from loss of pigment, which appears hypochromic in dark irides and hyperchromic in light irides. Other hallmarks are low-grade anterior chamber inflammation, posterior subcapsular cataracts, elevated intraocular pressure, and small, stellate, pancorneal keratic precipitates. Despite these findings, patients are often asymptomatic and the eye remains non-hyperemic. Reported associations include infections such as toxoplasmosis, CMV, herpes simplex, and rubella, though these links remain unproven. Now, let's move on to the glaucoma and classic signs seen in Fuchs' uveitis syndrome. Secondary open-angle glaucoma develops in roughly 15% of patients. On gonioscopy, you'll notice fine vessels crossing the trabecular meshwork, typically without a fibrous membrane, and only rarely causing peripheral anterior synechia or angle closure. Neovascularization may, on occasion, progress over time. These vessels are fragile, which means anterior chamber hemorrhage can occur either spontaneously or after trauma. The Amsler sign refers to anterior chamber hemorrhage following paracentesis during intraocular surgery. This is a gonio photograph showing Fuchs' uveitis syndrome. Notice the fine vessels crossing the trabecular meshwork, as highlighted by the arrows. What's important is that these vessels are not associated with a fibrovascular membrane. That means they don't lead to PAS or secondary angle closure, which helps distinguish this condition from other causes of neovascularization. Keep this in mind as a classic finding: delicate vessels without the aggressive sequelae we often worry about in other types of angle pathology. Now that we understand how fragile angle vessels and secondary open-angle glaucoma can develop in this condition, our treatment approach focuses mainly on controlling intraocular pressure. The primary strategy is the use of topical ocular hypotensive medications. However, IOP control can be challenging and doesn't always correlate with the amount of inflammation present. Corticosteroids generally aren't very effective for the low-grade chronic inflammation seen here, and they may even worsen IOP elevation, so they're not a mainstay in management. Let's move on to another important concept: elevated episclerovenous pressure, or EVP. EVP is a major factor influencing intraocular pressure, and in a healthy eye, it typically ranges from about 6 to 9 millimeters of mercury, depending on the measurement method. When EVP is elevated, we can trace the cause to a few main categories. Vascular malformations are one, including arteriovenous fistulas, whether dural or carotid cavernous, orbital varices, and syndromes like Sturge-Weber. Venous obstruction can also play a role, such as with retrobulbar tumors or thyroid eye disease. In some cases, systemic causes like superior vena cava syndrome are responsible. And finally, some cases remain idiopathic, which can even be familial. Understanding these causes is key for both diagnosis and guiding management. Now that we've covered the main causes of elevated EVP, let's look at how it presents clinically and how we approach diagnosis. Patients often describe a chronic red eye, but notably without discomfort, itching, or discharge. A careful history is important. Prior significant head trauma could suggest a carotid cavernous sinus fistula if high flow, or a dural fistula if low flow. While most cases are idiopathic, some may run in families. On exam, we might see tortuous, dilated episcleral veins that can be unilateral or bilateral, and in some cases, blood and Schlemm's canal on gonioscopy. Rarely, signs of ocular ischemia or venous stasis appear. More severe carotid cavernous fistulas can present with proptosis or other orbital and neurologic findings. When a vascular malformation is suspected, we turn to MRI or angiography. And if imaging is negative but suspicion remains, traditional angiography with possible interventional treatment such as fistula coiling may be considered if the benefits outweigh the risks. Now that we've reviewed how elevated episcleral venous pressure presents and how it's diagnosed, let's move into management. The mainstay of treatment is medical therapy, typically starting with topical ocular hypotensive drops, with aqueous suppressants often being the most helpful. It's important to recognize that laser trabeculoplasty is generally ineffective here, since the underlying issue isn't trabecular outflow resistance, but elevated venous pressure. If medical therapy fails, surgical intervention may be necessary, though this comes with special precautions, such as the heightened risk of ciliocoroidal effusion or suprachoroidal hemorrhage, so prophylactic sclerotomy or scleral windows should be considered. Moving from vascular causes to traumatic causes, non-penetrating or blunt trauma can trigger anterior segment changes that predispose to secondary glaucoma. Mechanisms include inflammation, hyphema, angle recession, and lens subluxation, which is further discussed in Chapter 10 under ectopia lentis. These changes, particularly when they occur together, can cause an initial spike in intraocular pressure after trauma. While the IOP rise may be brief, it can also persist, eventually progressing to glaucoma. In cases of secondary glaucoma following ocular injury, siderosis or calicosis can occur from a retained intraocular metallic foreign body, leading to chronic elevation of intraocular pressure. Chemical injuries, particularly alkali burns, can cause an acute rise in IOP through multiple mechanisms, such as inflammation, shrinkage of scleral collagen, prostaglandin release, anterior chamber angle damage, or disruption of uveal circulation. Finally, chronic or recurrent inflammation or damage to the trabecular meshwork can result in glaucoma developing months or even years after the initial injury. Now, it's important to focus on traumatic hyphema since it is one of the most clinically significant causes of post-injury IOP elevation. The risk for elevated pressure increases substantially with recurrent hemorrhage or rebleeding. This occurs in roughly 5 to 10% of cases, although the exact rate can vary by study population. Most episodes of rebleeding happen between 3 to 7 days after the initial hyphema. Larger hyphemas are associated with a greater likelihood of IOP spikes, but even small hemorrhages can cause significant pressure rises if the angle is already compromised. Continuing from the discussion on traumatic hyphema, it's important to understand the underlying mechanisms that lead to complications. The rise in intraocular pressure often occurs because the trabecular meshwork becomes obstructed. This can be due to red blood cells, inflammatory cells, debris, or fibrin, or from direct injury to the trabecular meshwork after blunt trauma. Performing gentle gonioscopy can help detect even subtle hyphema in the aftermath of trauma. As for complications, two key risks stand out. First, glaucomatous optic nerve damage can develop from prolonged IOP elevation. Second, corneal blood staining becomes more likely in eyes with hyphema if high IOP persists, underscoring the need for timely recognition and management. As we move from general mechanisms of injury-related glaucoma into specific high-risk situations, one important condition to highlight is sickle cell hemoglobinopathy. In these patients, the risk of elevated intraocular pressure after a hyphema is significantly higher, and they're more prone to optic neuropathy. The pathophysiology is tied to a lower aqueous humor pH, which promotes red blood cell sickling and rigidity. These sickled cells can become trapped in the trabecular meshwork, leading to an IOP spike, even when only a small number of cells are present. The optic nerve in sickle cell disease is particularly sensitive to these IOP spikes, which can increase the risk of anterior ischemic optic neuropathy and central retinal artery occlusion. This is due to compromised microvascular perfusion, meaning even modest IOP elevations can have devastating effects. When managing hyphema, the first step is conservative care. Patients should use an eye shield, limit activity, and keep the head elevated. Anti-inflammatory therapy can include topical or oral corticosteroids, although their effect on preventing rebleeding is uncertain. Cycloplegics are helpful for ciliary spasm or photophobia, but they do not reliably prevent rebleeding. Aminocaproic acid has been shown in some studies to reduce the risk of rebleed, but it carries significant systemic side effects and may cause a rebound rise in intraocular pressure after discontinuation. If intraocular pressure is elevated, aqueous suppressants and hyperosmotic agents can be used. For sickle cell patients, special precautions are necessary. Carbonic anhydrase inhibitors should be avoided due to the risk of sickling from lower pH. Systemic carbonic anhydrase inhibitors and hyperosmotics can precipitate crisis in dehydrated patients, and alpha-1 agonists carry a risk of vasoconstriction. Finally, parasympathomimetics should be avoided as they may worsen inflammation and increase the risk of posterior synechiae formation. When surgery is needed, the threshold is lower in sickle cell disease due to their vulnerability to optic nerve damage. In children, earlier intervention may be needed to prevent amblyopia if vision is obscured by hyphema or corneal blood staining. For high IOP, anterior chamber irrigation is typically the initial surgical choice. Total hyphema carries a risk of pupillary block, so an iridectomy may be performed during washout. Persistent IOP elevation may require glaucoma filtering surgery, and some surgeons combine filtering procedures with chamber washout for immediate pressure control, relief of pupillary block, and prevention of future IOP spikes. This image demonstrates corneal blood staining following ocular trauma. The photograph shows diffuse yellow-brown stromal discoloration of the cornea, which occurs when hemoglobin and its breakdown products infiltrate the corneal stroma after prolonged contact with intraocular blood. In this case, there is also a visible hyphema, with layered hemes settling in the inferior anterior chamber angle. This finding indicates significant or persistent anterior chamber hemorrhage, often associated with elevated intraocular pressure, which can drive blood products into the corneal tissue. Such staining may impair vision permanently if it involves the visual axis and is slow to clear. Now we are going to talk about two types of secondary open-angle glaucomas which are caused by vitreous hemorrhage. Hemolytic glaucoma occurs when hemoglobin-laden macrophages block the trabecular meshwork. These red-tinged cells are visible in the anterior chamber, and the trabecular meshwork itself may appear reddish-brown. Ghost cell glaucoma results from degenerated red blood cells, referred to as ghost cells, that obstruct the trabecular meshwork. These cells are small, khaki-colored, lack hemoglobin, and are less pliable, which increases intraocular pressure. Ghost cells usually form 1 to 3 months after a vitreous hemorrhage and can enter the anterior chamber through a disrupted hyaloid face, trauma, or surgical procedures such as pars plana vitrectomy, cataract extraction, or capsulotomy. Ghost cell glaucoma typically develops after a vitreous hemorrhage, most often following trauma, intraocular surgery, or in the setting of pre-existing retinal disease. In these cases, intraocular pressure is often markedly elevated, sometimes accompanied by corneal edema. The anterior chamber may contain degenerated red blood cells, and the degree of cellular reaction is often out of proportion to the amount of aqueous flare observed. Conjunctival inflammation is generally absent unless the IOP is very high. On gonioscopy, the angle usually appears normal, although layering of ghost cells is often seen in the inferior angle. In long-standing cases, the vitreous may appear khaki-colored, and extracellular pigment clumps can be found, resulting from degenerated hemoglobin. Here we see a slit lamp image showing the classic appearance of ghost cells in the anterior chamber. These are small, khaki-colored red blood cells that have lost their hemoglobin after a vitreous hemorrhage. Because of their rigidity and reduced deformability, ghost cells can layer in the anterior chamber, similar to how blood or inflammatory cells layer in a hyphema or hypopian. This layering contributes to obstruction of the trabecular meshwork, which is the underlying mechanism of ghost cell glaucoma. Now, let's review the management of hemolytic and ghost cell glaucoma. The first priority is controlling intraocular pressure, usually with aqueous suppressants as the initial therapy. If pressure cannot be adequately controlled, more invasive interventions may be necessary, such as anterior chamber irrigation, pars plana vitrectomy, or glaucoma surgery. Importantly, when collections of red blood cells or ghost cells persist in the vitreous, pars plana vitrectomy is often required to remove the source and prevent ongoing obstruction of the trabecular meshwork. Here we're moving into traumatic angle recession glaucoma, which is a secondary glaucoma that develops after blunt ocular trauma. This condition results from a tear between the longitudinal and circular muscle fibers of the ciliary body. That tear signifies probable trabecular meshwork damage, which predisposes to glaucoma. The onset is usually chronic and unilateral, and it can occur immediately after trauma or even years later. Clinically, it often resembles primary open-angle glaucoma in its course and symptoms. On gonioscopy, there are some classic features: a widened ciliary body band, absent or torn iris processes, a prominent white scleral spur, and irregular dark angle pigmentation. PAS may also form at the recession border. This is an important glaucoma type to recognize because it can easily be missed if the traumatic history isn't carefully elicited and the angle isn't examined in detail with gonioscopy. This image shows a classic gonioscopic view of angle recession. Angle recession occurs when the ciliary body is torn, most often between the longitudinal and circular fibers of the ciliary muscle. This results in a deepened angle recess, highlighted here by the arrows. The dark circular deposits seen on the peripheral iris represent old hemorrhage, further supporting a history of trauma. This gonioscopic finding is a hallmark of traumatic angle recession glaucoma, where damage to the trabecular meshwork impairs aqueous outflow, eventually leading to elevated intraocular pressure. Here we see another gonioscopic photograph highlighting the features of angle recession. The arrows point to torn iris processes, which are a hallmark of traumatic angle recession. In addition, you can appreciate a whitened and increasingly visible scleral spur, which stands out due to the tearing of tissue around it. There is also a localized depression in the trabecular meshwork, further confirming structural damage to the angle. When we suspect traumatic glaucoma, the key clue is unilateral elevation of intraocular pressure. A history of blunt trauma is often present, although patients may not recall it, especially if it occurred years earlier. On exam, we may find corneal scars, iris injury, angle abnormalities, or even anterior subcapsular cataracts. Phacodonesis may also be noted. Gonioscopy is essential, and we should always compare the injured eye to the fellow eye to look for angle recession. Several risk factors are important. The greater the angle recession, the more likely there is reduced outflow and a higher risk of glaucoma. This risk persists for decades after trauma, although it tends to decline somewhat with time. Importantly, up to half of fellow eyes can also develop elevated intraocular pressure, either due to prior unnoticed trauma or a predisposition to primary open-angle glaucoma. Because of these risks, patients need regular follow-up of both the traumatized eye and the fellow eye. Treatment usually begins with aqueous suppressants, prostaglandin analogs, and alpha-2 adrenergic agonists. Miotics may be tried, though paradoxical pressure elevation is possible. Laser trabeculoplasty is less effective in this setting. If pressure remains uncontrolled, surgeries such as trabeculectomy or other incisional approaches may be necessary. Let's move on to intraocular pressure elevation following surgery. Conventional surgeries, such as cataract extraction, often cause a transient rise in IOP. Laser procedures, including trabeculoplasty, iridotomy, or posterior capsulotomy, can trigger post-treatment IOP spikes that may reach up to 50 millimeters of mercury. More invasive surgeries, such as vitrectomy or PKP, may even result in sustained IOP elevation. The underlying mechanisms include the accumulation of inflammatory cells, red blood cells, debris, or pigment within the trabecular meshwork. Mechanical deformation of the meshwork itself, oxidative damage, and even angle closure can also play a role. There are also adjunct-related contributors. Corticosteroid therapy, frequently used postoperatively, is a well-known cause of IOP elevation. Additionally, viscoelastic agents can cause a transient and sometimes severe rise, with cohesive, higher molecular weight formulations carrying more risk than dispersive types. After surgery, intraocular pressure elevation is an important concern. Even brief postoperative spikes can cause optic nerve damage, especially in patients with pre-existing glaucoma. That is why IOP should always be monitored soon after both conventional and laser surgeries, and prophylactic pressure-lowering medications may be considered in higher-risk cases. If pressure rises, treatment typically involves topical beta blockers, alpha-2 agonists, or carbonic anhydrase inhibitors. Prostaglandin analogs are generally delayed if postoperative inflammation is present. In cases of very high IOP, paracentesis can provide rapid reduction. However, when elevation persists despite medical management, filtering surgery may be necessary. Now let's look at IOL-related secondary glaucomas. Lens implantation can set the stage for several types of secondary glaucomas, including UGH, or UG syndrome, secondary pigmentary glaucoma, and pseudophakic pupillary block. We'll go over UG syndrome in detail on the next slide. So, hang in there, we're almost done. Let's talk about UG syndrome. This stands for uveitis, glaucoma, hyphema. This condition develops when a malpositioned or rotated anterior chamber intraocular lens chafes against the iris or ciliary body. Clinically, patients may present with one or more key findings: chronic inflammation, elevated intraocular pressure, recurrent hyphemas, cystoid macular edema, or even iris neovascularization. Although anterior chamber lenses are the classic culprit, UG can also occur with posterior chamber lenses placed in the ciliary sulcus or sutured to the iris or sclera. Single-piece acrylic lenses in the sulcus carry particularly high risk and should be avoided. Diagnosis relies on gonioscopy together with ultrasound biomicroscopy to assess IOL position. Management typically involves repositioning or exchanging the IOL, though this becomes much more challenging if synechia are present or the posterior capsule is open. One important mimicker is neovascularization of a corneoscleral wound that causes recurrent hyphema and an IOP rise. In that case, treatment is directed at the abnormal vessels with laser ablation.
Now let's turn to secondary glaucoma that can develop after PKP. This complication is seen more often in patients who are aphakic or pseudophakic, and the risk goes up even further if the patient requires a second graft. The main causes include wound-induced distortion of the trabecular meshwork and progressive angle closure over time. Surgeons have tried to prevent this by using different-sized donor grafts, performing peripheral iridectomies, or even attempting iris sphincter repair, but that approach has had only limited success. One way to reduce the risk is to use lamellar stromal or endothelial grafts instead, which carry a lower risk of intraocular pressure rise compared to full-thickness grafts. Other contributors include long-term topical corticosteroid use, which can raise IOP, and the fact that surgical glaucoma treatments after PKP are associated with higher rates of graft rejection and graft failure. On this slide, we'll go over Schwartz syndrome, also known as Schwartz-Matsuo syndrome. This occurs in the setting of a regmatogenous retinal detachment. Normally, with a detachment, we actually expect lower intraocular pressure because outflow increases through the exposed retinal pigment epithelium. But in Schwartz syndrome, the opposite happens. The IOP is elevated. This occurs because photoreceptor outer segments break off and enter the aqueous, where they migrate into the anterior chamber and the trabecular meshwork. This blocks aqueous outflow and can mimic inflammatory cells or pigment in the chamber. The important clinical pearl is that the IOP normalizes after retinal reattachment surgery, so the key to management is repairing the detachment itself.
Here, we're shifting into corticosteroid-induced glaucoma, which is one of the most clinically relevant forms of secondary glaucoma. This condition looks very much like primary open-angle glaucoma in terms of optic nerve and field changes, but the trigger here is steroid exposure, whether topical, periocular, intravitreal, inhaled, or oral. About 1/3 of otherwise non-glaucomatous patients will have a moderate IOP rise of 6 to 15 millimeters Hg, while a smaller percentage, around 4 to 6%, can spike more than 15 millimeters. On the other hand, in patients who already have POAG, nearly all will show a hypertensive response with prolonged topical steroid use. Risk is especially high in patients with a history of POAG, first-degree relatives of POAG patients, children under 6, older adults, those with connective tissue disorders, type 1 diabetes, and myopia. Mechanistically, this is due to increased resistance to aqueous outflow at the trabecular meshwork. The degree of IOP rise depends on both the potency of the steroid and the frequency or route of administration. Some patients can develop significant pressure elevation relatively quickly, while others may only show a delayed response. On this slide, we'll look at the clinical course and drug factors that influence corticosteroid-induced glaucoma. The onset of IOP elevation can be unpredictable, sometimes occurring just weeks after starting steroids, but in other cases, months or even years later. This is why regular IOP monitoring is crucial for patients on long-term therapy. Potency and ocular penetration play a central role. Steroids with higher glucocorticoid potency and better penetration are more likely to raise IOP. For example, fluorometholone, remexolone, medrisone, and lodiprednol are less likely culprits, whereas prednisolone, dexamethasone, and difluprednate are much more potent and more likely to cause a significant rise. Importantly, even weaker steroids or lower concentrations can trigger IOP rise in susceptible patients. If unchecked, this steroid-induced rise in IOP can lead to glaucomatous optic nerve damage. IOP elevation can also be compounded by underlying ocular diseases, such as anterior uveitis. After discontinuing steroids, pressure usually decreases, though in some cases the elevation may persist. And remember, this condition isn't limited to exogenous steroids. Endogenous corticosteroid excess, as seen in Cushing syndrome, can have a similar effect. Now let's look at corticosteroid-induced glaucoma in the setting of periocular and intravitreal use. Periocular injections, especially with triamcinolone, are well known to elevate intraocular pressure. In some cases, patients may even require depot excision or glaucoma surgery. With intravitreal injections, more than half of patients experience an IOP rise. Around a quarter of them will require topical medications for control, and a small percentage, about 1 to 2%, will eventually need incisional glaucoma surgery. Intravitreal implants tend to raise IOP even more frequently than single injections, and these patients are more likely to require glaucoma surgery. When surgery is needed for steroid-induced glaucoma, the outcomes are generally favorable, with a high success rate for pressure control. Laser trabeculoplasty can also be considered in select cases.
On this slide, we're shifting focus to drug-related intraocular pressure elevation, specifically from cycloplegics and anti-VEGF agents. Cycloplegic drugs can raise IOP even in open-angle eyes, with higher risk in patients who already have primary open-angle glaucoma, pseudoexfoliation syndrome, pigment dispersion, or those on meiotic therapy. Even routine dilation may elevate pressure in susceptible patients. Now, moving to anti-VEGF agents. These intravitreal injections, commonly used for choroidal neovascularization and macular edema, can cause a transient IOP rise. With repeated injections, this may progress to a more sustained elevation. The exact cause isn't fully understood, but proposed mechanisms include inflammation, trabecular meshwork injury, or mechanical blockage.
Congratulations! You've made it through a long and detailed lecture. I know we covered a lot of ground, but each piece builds toward a clearer understanding of secondary open-angle glaucomas. Thank you for sticking with it all the way through. Before we officially wrap up, there will be a set of review questions at the end to test your knowledge and help reinforce the key concepts. So hang in there just a little longer. You're almost done.